Hello, thank you so much for joining us today. We're looking forward to providing information about the project toward consistency for aligning state approaches to the behavioral health and substance use paraprofessional workforce. We're really excited to be welcoming folks from national organizations and states that have learned about the project and are interested in learning more and how they can get engaged. As we get started today, I'd like to take a moment to introduce myself and my colleagues that are here providing support for the webinar before we dive in. My name is Hannah Maxey. I'm an associate professor at Indiana University, where I am also the director of the Bowen Center for Health Workforce Research and Policy. I have the privilege of serving as the principal investigator and lead on this national project. So I'll be walking us through everything today. I'm going to hand it over to my colleague, Michaela, to introduce herself and how she'll be supporting the webinar today.
Thank you, Hannah. Hello, everyone. My name is Michaela Moore. I am the policy analyst supporting Hannah in completing this project and making sure that everything gets finished. I will be managing the question and answer chat today. So if you have any questions as we're walking through the presentation, please feel free to put them in the chat and we will either respond to them as soon as we can get to it, or we'll have a little section for question and answer at the end. Cleveland.
I'm Cleveland Dietz. I'm project manager at the Bowen Center, and I am providing project management support for this project. I'm excited to do so. I will also be monitoring things in the chat as things go on, and yeah, I'm excited to share what we've got going on. Back to Hannah.
Thank you so much, Cleveland. Okay, well, let's go ahead and dive in. So I wanted to do an overview of what's ahead for our time together today. I'm going to start by making the case for this project. I think if you've joined, you probably are interested in behavioral health and substance use workforce as a topic, either within your own organization or also for the members and network that you work with. So we're going to make the case and talk about what is the need for this project. Then we're going to pivot and I'm going to do a high-level overview of the project itself, and then share some early findings with you all and round us out with a discussion of where we go from here and how you can get involved. So we're going to start with making the case. And I want to take a moment to not sound all doom and gloom, because there is a space for us to recognize the progress that we've made here in the United States in recent years, while we're also talking about continuing forward to address mental illness and substance use disorders here in America. Recent stats that I'm sure many of you are familiar with out of SAMHSA, 61.5 million adults have mental illness. That represents just under a quarter of all adults over the age of 18 in the United States. Among these adults, 31.5% also have a reported substance use disorder. So we are talking about challenges that are impacting a significant portion of our population that the workforce of behavioral health and substance use professionals are engaged with. Where I think we have some opportunity to recognize and celebrate our progress nationally is when we look at drug overdose deaths in the US. And I'm sure many of you have also seen these statistics in the work that you do. But we are all aware that over the last several decades, the number of drug overdose deaths in the United States has increased rapidly. But there has been good news in the last several years with a decrease in drug overdose deaths here in the United States. Clearly, progress is being made. And of course, there are lots of things that have gone on during that time period that have contributed. Regardless of the progress that we have made in the United States, we definitely have a long ways to go to addressing mental illness among our population and to preventing drug overdose deaths here in the United States. And one of the important pieces, not the only piece, but one of the most important pieces, is ensuring that we have a workforce of individuals trained, ready, willing, and available to provide care and services for individuals in the communities when they need it. So that brings us to a major problem. Workforce shortages in mental and behavioral health and substance use are pervasive. Although this workforce is desperately needed for a huge segment of our population, recent data from the U.S. Department of Health and Human Services, Health Resources Services Administration on our health professions shortage areas for mental health show that nearly the entire United States and all states are impacted by mental health workforce shortages. Don't worry, you don't need to lean far in and try to put readers on to see the legend there. The bottom line is when you're looking at this map produced by HRSA, any of the states, any of the geographies or communities that are colored in blue, any shade of blue, are designated as having a shortage of professionals. So you can see all states are impacted and the majority of communities are impacted by health workforce shortages in mental health. So clearly workforce shortages are at crisis proportion. Addressing those shortages are a key priority for states, organizations, and nationally in order to continue to move the needle on mental health, behavioral health, and substance use conditions. So I want to switch gears and now talk about workforce alignment. And you may see this and wonder what this is. When we think about the workforce that is needed to provide medical care, dental care, or mental health, behavioral health, or substance use care to our population, those workforces, depending on what sector we're talking about, are comprised of a wide array of professions and occupations that deliver those services. What you're looking at here on the screen is an infographic, and this is for illustrative purposes, but it is based on U.S. Bureau of Labor Statistics employment that is reported. And this is looking at, on the left-hand side, in our medical care system, we have a large number of support professionals, paraprofessionals, technicians, and other professionals that provide care, provide services, provide support, and extend service delivery under our doctorally prepared, trained physicians and other professionals. This is just an illustrative example. Across the United States, for every one physician that we have approximately 7 what we're calling supportive professions that are bachelor degree or less and regulated by states. So who does this include? Registered nurses, certified nurse aides, respiratory technicians, the whole gamut of the workforce that provides and supports the healthcare delivery system. In the dental care system, which I had to throw in because my background is as a dental hygienist, we also see something similar, where for every one dentist that we have here in the United States, we have at least 4 professions that are extending those dental care services. That includes dental hygienists and dental assistants, both of whom there are regulations at the state level in most states. It's very different when we get to mental and behavioral health. In mental and behavioral health, our clinician workforce is comprised of psychiatrists, clinical psychologists, and master's trained clinical counselors and therapists. We do not have a robust foundational workforce in mental, behavioral health, and substance use represented by state regulated occupations. In fact, when we look at occupations such as psychiatric technicians and peer support specialists, we see that for every one mental health and behavioral health clinician, we actually have only 0.2 support professionals. So this brings us to workforce alignment and right sizing the mental, behavioral health, and substance use workforce. So let's talk now about paraprofessionals. This project is focused on behavioral health and substance use paraprofessionals, and I just laid out the challenge that in healthcare we have all of these foundational roles and supportive roles and paraprofessional roles and professions that help support the delivery and services of those clinicians. In mental health and substance use, our clinicians do not have consistently those roles to provide support to them. This is leading to burnout, and it's leading to significant burden of non-clinical tasks among a workforce that is already in shortage and already strained. And with a lack of formalized paraprofessionals to provide support, these clinicians are going to continue to experience burnout, and we will continue to see long wait lists and significant shortages here in the United States. The great news is states have begun to formalize behavioral health and paraprofessional roles, but those do not currently have a national strategy for standardization to support alignment and consistency across states. So that brings us to the strategy for this project, which is focused on understanding how states are developing this workforce of behavioral health and substance use paraprofessionals, and developing a national framework that will help us move towards consistency for this critical workforce across the states, and also with considerations of accessible career pathways and expansion of workforce capacity. So before I get into the specifics of the project, I do want to define really clearly who are behavioral health and substance use paraprofessionals that we are really focused on in this project. I want to talk about the workforce context first. We are specifically looking at state-regulated behavioral health and substance use paraprofessionals. So those would be what we're calling paraprofessional roles that one or more states have developed and have occupational regulation for that role within their state. They have to be a role for whom there are currently no national standards. So there's no national standard on the curriculum, no national standards on credentialing have been developed as of yet. Also, they have to be jobs that are open and available to all individuals that would like to gain entry into the behavioral health and substance use sector. So we recognize the critical role of peers, peer support specialists, but those roles do require lived experience. And so therefore, and we do have national standards and consensus around the training and education and credentialing for those workforces. Finally, they have to be fully dedicated to substance use and behavioral health services. So while workforces such as community health workers are critical in communities across the United States and are making contributions for behavioral health and substance use, they are not fully dedicated to behavioral health and substance use services, and so therefore they are not included. They also have standards that exist. So state regulated in one or more states, no national standards exist, no lived experience requirements, fully dedicated to substance use and or behavioral health services. We're also looking at and defining paraprofessional with an education level. We specifically classified roles as having a high school diploma and some other type of specialized education that may be career and technical education, on-the-job training, or et cetera. The next level that we looked at were those that require an associate's degree, and finally, those that would require a bachelor's degree. So we limited the study to state-regulated roles that fit the workforce context that have one of those education levels, specialized training, associate degree, or bachelor's degree as the education level for entry. Finally, we looked at the roles and responsibilities of these folks and what they were authorized to do, including psychosocial skills training, care coordination, prevention services, and supporting licensed clinicians under supervision. So when we are talking about behavioral health and substance use paraprofessionals in this study, this is what we're talking about. So now I'm going to dive right into the project. So the project has several work streams that some of which are going on and that we're going to talk about the outcomes today and the findings today, some of which are going to be ongoing into 2026. The first, and I'm going to be sharing some early findings, is a 50-state policy review. So I shared we're interested in identifying which states have formalized and have occupational regulation for behavioral health and substance use paraprofessionals. We did a 50-state policy review, and I'm going to go more in depth on that to identify those states and those roles across the United States so that we could learn from them. We also have done a wage analysis exploring the labor market in the health sector broadly to produce wage estimates for the purpose of informing conversations and policy planning related to new behavioral health and substance use paraprofessionals to inform those conversations related to the wages that would be needed to sustain these jobs and make these good and competitive jobs. We're doing this now, working to develop and solicit participation for key informant interviews from states to learn more from states, but also from national organizations that are involved in this space, as well as other organizations that might be involved, providers and employer organizations, even professionals themselves, if we're able to find them. In 2026, we're going to bring folks together here in Indianapolis for a roundtable convening to review all of these findings, lessons learned, all of the information that we gathered in the engagement to help us map out a framework to move us as a nation and as states towards consistency for behavioral health and substance use paraprofessionals. So I am about to dive into the initial findings, but I just wanted to kind of share with you how this project is truly starting with the end in mind. Because I think as a policy researcher and a state health workforce policy researcher, sometimes people ask, what is that? What does that mean? And how does that actually relate to population health or access to services? This study started by looking at states that have created occupational regulation for behavioral health and substance use paraprofessionals. That's important because those state laws that regulate these professions define the types of education they need, define the services that they can provide in communities, and the conditions under which they can provide those services. Those regulations at the state level then are related to and intersect with reimbursement for the services that those folks can provide and tie directly to whether an individual workforce can be enrolled in health insurance programs as a provider, or whether the services they're providing might be covered services or included in packages to reimburse for services. So occupational regulation is related to reimbursement structures. It also, by virtue of designing and setting the standard for the education criteria and the scope of practice or the services they can provide, has an influence on the workforce systems, which are education vendors, academic programs and institutions. Those have to align with whatever the state occupational regulations and standards are. And of course, providers and employers and practitioners in the community can employ those individuals, or those individuals can use those skills to deliver services as a state has defined. Ultimately, all of these things lead to things that we can actually measure at the state level and at the community. The first are workforce outcomes, which is very important. So how many people actually get those state credentials and become part of that regulated occupation within a state? How many actually work in that and use those credentials within the state? Where are they working? Who and what populations are they providing care for? Those are workforce outcomes, as well as, of course, importantly, what is their wage and what are the characteristics of their jobs? Finally, and of course, most importantly, starting where I started this entire webinar off, the population health outcomes. All of this occupational regulation, all of the reimbursement structures, the workforce systems, the workforce outcomes, the people in these jobs lead to and should be designed around supporting population health. Specifically in this case, improving, enhancing, and ensuring access to behavioral health and substance use services. So we should be able to quantify, measure access, outcomes, and well-being within populations and communities. I just wanted to start with the end in mind so that you all knew very clearly how this project is tying from state occupational regulation for behavioral health and substance use paraprofessionals all the way down to the health of our populations and communities. Okay, without further ado, we're going to dive right into some of the findings from two of the work streams that we have already finished. The first is our 50-state policy review. And this review involved us pulling together a team of experts. And so I wanted to call them out and recognize and acknowledge them for their contributions. Our team that you met was joined by Dr. Ashlyn Burns, who is an assistant professor in the Department of Psychiatry here at Indiana University School of Medicine. She brought expertise in health services research and in the space of mental health and substance use. We were also joined by Mr. Stephen Steed, a third-year law student at the McKinney School of Law here at Indiana University. So we had a great team. The process for our 50-state policy review, we implemented it as a formal legal mapping study. And I'd like to acknowledge right now that we received excellent guidance and consultation from Temple University and their excellent team on methodology for the legal mapping process and methodology. We were so grateful for the guidance that we received from Temple and the team at Temple. So the process that we used, it was very formal. We had a systematic review of state statutes, state laws, regulations, so administrative code, rules, and Medicaid documents across all 50 states and the District of Columbia. We use legal search engines, legal databases, specifically Westlaw for those searches. And we used keyword search terms and an iterative process of review to identify roles for full review and inclusion or exclusion into our study. I'm going to present a high level today. We do have papers and reports that are forthcoming that will lay out all the methodology for those that are deeply interested in learning about that. After we did our systematic review of state policy, we then went through a process of categorizing our findings based on the form or type of regulation that each of the roles we identified fell under. And so when I say type of occupational regulation, I want to define that really quickly. We looked at 3 levels of occupational regulation. The first level being licensure. And licensure offers a title protection, meaning a name. So a licensed social worker, for example, is a title, but it also offers and defines a scope of practice or services for that profession that is protected for that profession. So licensure is the highest form of occupational regulation, offering both title protection and scope authorization and protection. The next level is state certification, and certification offers title protection, but does not offer scope protection. So other individuals may do on-the-job training and be able to provide some of the services that those certified individuals provide, but they may not use the title certified that as an individual that holds that certification. That is the second level of occupational regulation. The next level down, and the final level that we looked at was registration. That is the least onerous occupational regulation level, and registration is basically just a list of individuals that is publicly available. So we looked at all three of those. We also looked at the education, classifying them, as I've already shared, as specialized training, associate degree, or bachelor's degree. We looked at the scope of practice, and I'll have a slide that goes into that. And we also looked at reimbursement, specifically whether or not the state had any reference to or provisions for reimbursement, naming these roles as enrolled providers in their Medicaid plans and programs, or referencing their services under services that were covered. Finally, we sent out our findings to states to get validation on them, and we were really excited that we heard back from many states. Drum roll, what did we find from the legal mapping? Many states have developed some type and form of behavioral health or substance use paraprofessional roles. In fact, we found 102 roles across 38 states that fit the criteria that we used for behavioral health and substance use paraprofessionals. And of course, that includes the District of Columbia. Our review included all roles. So I want to share with you the map here. If it's gray, no role was identified. If it's a level of blue, you can see how many roles were identified. We did review roles in the states that do not have a behavioral health or substance use paraprofessional. And we identified that those roles didn't qualify under the criteria, and we validated that with states as well. So the majority of our states have one or more of these roles that they have established that are unique to their state. So let's talk about the characteristics of these roles. First, I want to focus on the level of regulation. The largest group that we identified were certified roles. So remember, those are roles that have title protection. And of course, they would define education requirements in order for someone to qualify, and likely examination requirements in order for someone to qualify to apply for that certified profession and become a certified professional. But that was the largest group of roles that we found across the states were a certification level. The second most frequent group that we found was licensure. So again, those were roles, occupations that had both title protection and a defined scope of practice. The smallest group was registration. That is the lowest, I guess, barrier entry for occupational regulation, and signing up on a list and meeting the criteria to be on that list. If you're looking at the outer ring here, that is actually reimbursement provisions. And so what we've done is show the breakdown of the certified roles that we found and what percent of those roles had very specific reference within Medicaid reimbursement, guidance documents, and provisions for those roles. For the certified occupations, 73% of those roles, there were provisions within Medicaid to provide some type of reimbursement for the services that they provide. When we look at licensure, we see that go up to 81% of the roles. In those states, there were specific provisions. For those that were registered, it was about 50-50, whether or not there was any Medicaid related provisions. The next category that we looked at was the education level. So specialized training, as a reminder, was a high school diploma plus some additional defined education defined by the state that was less than a bachelor's degree or less than an associate degree. So it was not higher education degrees. And you'll see that was the largest share at over 2/3 of the roles had some type of specialized training defined by the state. The next largest group was a bachelor's degree was the entry requirement, with the smallest group being the associate degree as the entry requirement. The last characteristic that we're going to talk about briefly today is the regulatory authority. So one of the things that we wanted to identify when we dug into this in our state research is, so in state government, what agency or entity is involved in regulating these professions or roles and occupations within the state? And so we've collapsed this into 3 groups for the purposes of discussion today. And those 3 groups are occupational licensing board. So that is what you would think of, you know, a social work board, a board of nursing. And so over half of the roles we found were regulated by a occupational licensing board within the state. The next largest group was regulated by a agency or entity that we classified as a health and human services agency at the state level. And for health and human services, we included health and human services, social services, departments of health, and mental health and addiction divisions and agencies. We have all of that broke out, but for protection of time today, we grouped them all together. And so that was the second largest executive branch entity that regulated these professions. The last group is regulatory agency. And so these are states where there is a broad umbrella regulatory agency that is not affiliated with Health and Human Services and is not a dedicated licensing board, but regulates those professions. And you can see that was the smallest group. So scope of practice, what are these roles doing? What did we find? What I'm going to share with you today is what we found from our review of scope of practice. And we implemented that by using the key terms from within the state statutes or state rules related to these professions. And we documented anytime a specific service was mentioned within code. And so this is across the mentions. We're going to look at, for each level of regulation, whether or not that service was able to be provided independently, meaning someone that's a behavioral health paraprofessional or substance use paraprofessional could do screenings and assessments independently, that's the coral color, or whether there was some level of supervision required for them to do those services. And supervision could range from direct supervision, meaning someone was physically present and supervising the professional, all the way to general supervision or telesupervision. So the first was screening and assessment, and you can see the levels of regulation here. Not surprisingly, licensure, the group that has licensure, had the highest level of ability to provide screenings and assessments completely independently. Although we do see that about a quarter of both the registered and certified occupations were able to do that completely independently. The next cluster of services we grouped under brief intervention. And you'll see here similar for the registration group, they were only able to provide brief intervention under supervision, whereas for the certified and licensed roles, we see that a significant proportion of those roles were able to provide that brief intervention completely independently, with licensure having the highest, not surprisingly. For general counseling, we have, again, the same trend. We see that licensed roles have the highest ability to provide general counseling independently. And the last and very critical is the substance use counseling that was reported. And you can see across all the roles, there were a significant share that were able to provide it independently, but licensed roles had the highest level reported of providing substance use counseling independently and not requiring supervision. So we have a paper that's going to do a deep dive into this, and we'll look forward to anyone who wants to engage more on this reaching out to engage with us. So very quickly, I shared we validated findings, And so this is just a map that shows all of the coral states are states where we sent what we found for the legal mapping, the policy review, and that state validated one or more of the roles that we identified. So you can see the majority of the states did come back and validate to us or provide updates to us on our interpretation to make sure we got it right. And we are still working with those states we haven't heard from. If you've got a contact there, we'd love to connect. So let us know to make sure that we interpreted those roles correctly. Right now, we've pivoted to key informant interviews, and we're working to do a deep dive with states and others, such as yourselves and others nationally, to get insights and learn more about implementation strategies and considerations, workforce outcomes, and lessons learned. So that's underway now. I'm going to dig right into our labor market findings. Just wanted to remind you, feel free to drop any questions in the Q&A feature. If you have any, my colleague Michaela is minding that. So our labor market analysis to do wage estimates, we had a fabulous team that worked with us on this project. I want to acknowledge them quickly. Dr. Laura Montenovo at Purdue University, who is a health economist, worked very closely with us on the analysis that I'll be sharing. Dr. Kosali Simon here at Indiana University at our School of Public and Environmental Affairs was the senior expert advisor on this work stream. And then Rachel Carpenter, a PhD candidate in that program, also worked closely with us on this analysis. So the purpose of our labor market analysis was to provide basic information to policymakers and advocates on what type of wages would behavioral health and substance use paraprofessionals need to make, or at least wage estimates to inform conversations about what would be appropriate wages for those roles based on their entry level of education, given the current employment environment in the healthcare sector and those jobs that these roles would be competing with. So I'll go into what that means. Obviously, these behavioral health and paraprofessional roles that we are researching, they aren't standardized across the states. There's no national reporting or state level reporting consistently for these roles that we can go to see what are these paraprofessionals in these roles currently making, within each state. So we had to identify occupations in the health sector with comparable levels of education that were also state regulated and look at their wages to produce estimates that might inform conversations about behavioral health and substance use paraprofessionals. And so we had a great team working on this. I'd also love to acknowledge that we reached out to some experts nationally and got some guidance from them as we created these roles and identified comparable occupations that were state regulated. We then went out and collected and gathered data, employment and wage estimate data, and data on benefits from the Occupational Employment and Wage Statistics and the Current Population Survey. And then ultimately, we estimated wages, calculating state level wage estimates for each education level of occupation that we looked at. And so labor market analysis, who were our comparator occupations? And I'm sure some people will look at this and they'll wonder how we classified these. We developed these classifications using the Department of Labor, Bureau of Labor Statistic, federally reported and documented entry education level requirement for these occupations. So I say that because you'll note that registered nurses is under Group B, which is associate degree. That is because the entry level requirement is an associate degree. Now, I'm going to share, we are very well aware that many folks that are registered nurses have a bachelor's degree and that is also a common pathway for entry. However, it is entry at an associate degree minimum. So that's how we classified these groups and created what we're calling occupational health sector bundles of state-regulated occupations to look at their wages. So I'm going to go through the findings, and I'm sorry, I know this is really small. We wanted to have all 50 states and the District of Columbia up here so that you can see them. We're recording this. We're going to send it out. This will be published so that you all can have this data. But the first group of, the first occupational comparator group we're looking at are those state-regulated health sector occupations that have specialized training requirements. So not an associate degree, not a bachelor's degree, some type of specialized training as their entry-level requirement. The national median for these roles is about $18.63. That's the trend line that you can see. And you can see, of course, that the wages for these roles vary widely from state to state. Now, I want to share, we did not do any adjustment for cost of living at the state level because we wanted to produce wage estimates for each state based on what is reported for comparable for occupations with comparable education requirements within that state. So there are other analyses that we have done and plan to do and include in the reporting, but these are actually just the median wages at the state level for the occupational groups and with comparable education. The highest wages for this group are found in the state of Washington, about $23.50 an hour. The lowest are found in Louisiana, so about $14.30 an hour. Associate degree, we found some different things. So this is not going to be surprising given that we included registered nurses in this category because the entry-level requirement is an associate degree. But the national median wage for health sector occupations in that comparable group for the associate degree is $42.60 an hour. And of course, again, there's wide ranges in the median hourly, with the highest being California, coming in at $63.56, and the lowest being found in South Dakota, which is $33.39. And of course, we've done lots of breakout of this data, but we wanted to present you with just some high-level summary of it. This is the bachelor degree finding, and we're going to go to a slide that shows them all at one time. But for the bachelor's degree finding, we actually found for bachelor's degree health sector occupations where the bachelor's degree is the minimum entry requirement, that the median hourly wage was less than the associate degree, and it was at $28.68. Now, again, we know that occupations that are in high demand and command salaries, high hourly wages, such as registered nurses, are skewing that. But we do think it's important to present the data as the data stands. And so for the bachelor's degree, the highest wages were found in the District of Columbia at just under $38 an hour, and the lowest were found in Mississippi at $22.21. This is the labor market estimates side by side, and you can clearly see that that associate degree group of health sector occupations actually has the highest wage across states, the highest median with the bachelor's and the specialized training. Again, these data are solely prepared to inform policy discussions and are not trying to say this is how much someone should make. Rather, they're helping to inform conversations among states at how much would these jobs need to make them competitive and good jobs. I'm not going to go through this in detail. I know we're about at time, but we did look into industry to identify how industry might play a role. The industry that these roles are working in might play a role in the wages. We looked at all industries that these occupations work in, and we also broke it down into industries associated with patient care and consumer care. Not surprisingly, there are wide variations by industry. If you look at what we have on the right, the lowest paying industry was social assistance, and the highest paying industry, not surprising again, in those roles where in industries and direct patient and consumer care were hospitals. So I'm going to round us out really quickly. I apologize. We had a lot of information to get through, but where do we go from here? We are in the midst of key informant interviews. So some of you that joined today, we may have reached out to. We'd love to connect with you. If you have folks that we should connect with, please make introductions to us. We would really appreciate that. We are planning for and looking ahead toward the roundtable in 2026 that will occur here in Indianapolis in person. And then in Q4 of 2026, we'll look forward to having a draft framework put out for public comment and then launching it in Q1 of 2027. I'll leave you with, we have this QR on the screen today. And I would really appreciate it if you take about 3 to 5 minutes to complete that brief survey. It's a pulse survey. We will be sending the link out via email to everyone that registered to attend today. We'll also be trying to elevate the survey through social media and other targeted disseminations to get insight and perspective from organizations on the topic of behavioral health paraprofessionals, whether they think there's interest and will for this discussion, etc. So we'd love for you to complete that. I apologize that we ran out of time for Q&A, but I will promise you, if you dropped a question into the chat, we will follow up with you. And if there were questions that we think will be particularly relevant for everyone that attended today, we will send the response to those in follow-up. Thank you so much for joining us today. Thank you for your interest in this topic. And we hope that you will engage with us and join us in this important work. There is no silver bullet, but we all need to do the good that we can. So thank you so much.